When admitting a patient to our hospital, we use a carbon copy consent form. This includes things like the patient's name, the owner's name, the procedure to be performed, as well as medications needed and optional or non-optional diagnostic testing depending on the patient's risk factors. It also will include the anticipated cost for the visit. So the owner must sign off and authorize us before we can go ahead with the procedure. And then once they sign off, we be sure to get the best number to reach the owner at in case we have any questions or concerns. And then we would give them the top copy of the consent form to keep. And then after that, we'll be good to go ahead with the procedure. Today we'll be performing a canine ovariohysterectomy on a 9-month-old female Jack Russell Terrier who has no known medical problems. Our hospital uses the Cornerstone computer software to hold and organize each patient's permanent medical record. It contains everything you need to know about the patient, and you can easily search for the patient by their name, the owner's last name, phone numbers, email address. And in those records, you can find everything from their vital signs, vaccination history, prescription history, and phone call conversations. The only thing not in our record would be x-rays, which we keep in our radiology x-ray library. If the patient were seen at a different veterinary clinic, we wouldn't want to get the records from the other vet clinic, and we would upload those records into our medical history, and it would then become a part of our medical history for that patient as well. Before releasing a client's information to anyone, whether it be another vet clinic or a pet adoption agency calling in to find out if a client of ours would make a good pet parent, you must always receive the client's authorization to do so first. And you always have to document in the record whether or not you got their consent. So obtaining the owner's consent is very important in many aspects of the hospital. That's why our admission form also doubles as our consent form. We have a full consent portion at the bottom of our admission form that they have to sign off on. If they don't, we wouldn't go ahead with the procedure. Another pretty common thing, owners want to know what they're consenting to. So a pretty common question is, what exactly is an ovariohysterectomy? So in that situation, I would tell the owner that we'll be using a general anesthetic to surgically remove your canine patient's uterus and ovaries. And this will vastly reduce the chances of her developing pyometra or mammary cancer in the future, as well as preventing unwanted pregnancies and heat cycles. Each patient admitted to the hospital has a Vtht collar placed around their neck, and this identifies the patient's first and last name, their species, breed, weight, and also the clinic name and phone number. Affixed to their clipboard on the front of their cage, we always have a travel sheet, and on the travel sheet it says the patient's name, the procedure to be performed, and then we have various yes or no check boxes to say whether or not the patient needs pre-anesthetic blood work, if their pre-med was given, that the pre-surgical exam was performed, and if things like warming devices are necessary throughout their procedure, and which ones the doctor recommends for them. Just in case there's any further confusion of the procedure being performed, we do keep a copy of the signed consent form affixed to their clipboard as well. And then also we have 2 additional forms, a pre-sedation anesthetic form and an anesthetic monitoring log that also have check boxes to note whether we verified the procedure to be performed. And lastly, every patient admitted to the hospital should have a treatment sheet affixed to their clipboard. This once again notes all of the patient's information, the procedure to be performed, and then we document any vital signs taken throughout their stay, as well as any treatments or medications given throughout the duration of their stay. We use the IDEXX reference lab for most all of our diagnostic tests. So how it works is whatever code you need, whatever test you need, you type it in on the patient's PVL. So we'll be doing a urinalysis on my cat. So I'll type in the code, and then it's going to prompt the form. It's not this one. And then they'll occasionally want you to put details as far as like sample collection. For example, for the urinalysis today, it wants specimen details, so I'll choose cystocentesis. And then I just hit order, and then it simply prints out the form for me. And on the form, it populates all of our clinic information, all of the patient's information. And then it also will print out a sticker, which I'll affix to the urine tube that we'll be sending out. And here's what the printout looks like for the IDEX urinalysis sample I'll be sending out, and the sticker that I'll affix to the tube I'm sending out. If this was like a tissue biopsy, they would want a lot more details as far as how you collected the tissue itself, and then just a little bit of details about the history of the sample you're sending in. Our hospital uses 5 key anesthetic forms. The first one is a pre-anesthetic form. So this documents in detail that the patient's pre-anesthetic evaluation was performed and all the details of that. We list any current medications they're on, their ASA, risk assessment, just other things such as that their IV catheter was placed, their monitoring plan throughout the procedure, and any details of the diagnostic testing that was completed. The second form we have, it's a pre-calculated emergency drug form, and the drugs are calculated based off of the patient's current weight, and we just keep this readily available in case there's any unforeseen circumstances throughout the procedure. The third form, it's our anesthetic monitoring and record log. So on this, we have a lot of safety checklists on here. We have a pre-surgical checklist for the patient. We have a safety checklist, and then also an equipment checklist. This table here, this includes different drugs, fluids, and anesthetic agents and carrier gases, things like that used throughout the procedure. We just document the specifics of everything, such as the doses and rates given, the initials of who gave the item, and then the specific time on when it was given. Next, we have our actual monitoring log, which we use throughout the anesthetic procedure. We chart things out by hand every 5 minutes, and we'll document their temperature, pulse, heart rate, respirations, diastolic, systolic, mean arterial pressure, pulse ox, and end-tidal CO2. Lastly, we follow up with a post-anesthetic or sedation monitoring log. So with this log, we monitor the patient every 15 minutes after their procedure is stopped. And we'll continue to monitor them every 15 minutes until they've reached a stable condition. When discharging patients from the hospital, we review and send home a copy of post-surgical care instructions. What we'll go over in this is that their pet is going to have some clipped hair from the procedure. We let them know that they should keep their pet's activity minimal and keep a very close eye on them during the recovery period. As far as things that are abnormal to look for, this would be any swelling or distension at the abdomen, any vomiting, lethargy, or if there's any redness or inflammation at the incision site. If they notice any of these things, they should call the office immediately. We do let them know that there may be intermittent coughing once going home, and it's just from placement of the endotracheal tube in the esophagus, but it usually resolves within a couple of days. They should be sure that they do not let their pet lick at, chew at, itch, or do anything at all to affect the surgical or incision area. If they are bothering the area, usually it's pretty common for them to lick. They'll want to get an Elizabethan collar to prevent them from reaching that area. The medication that we'll send home, the pain medicine we'll send home, is the NSAID Rimadyl. And we'll send this home with canine neuters, canine spays, and it's highly effective against both visceral and somatic pain. Side effects to look for would be vomiting, black tarry stools, gastric bleeding, and inappetence. And owners want to be sure that they do not give it in combination with corticosteroids, or this could cause gastric ulceration. For a jugular blood draw, you can have your patient either sitting or in sternal recumbency. You want to make sure that you hold their head up in whatever direction the person collecting the blood sample needs, and obviously face their head towards the person collecting the blood sample. Just when holding their head in place, you want to make sure that your hand doesn't block the view of the vein. When collecting a cephalic blood sample, they can once again be sitting or in sternal recumbency. And then you want to hold under the chin with one hand and then hold behind the elbow of the leg where the blood sample is to be collected, while you're also somewhat extending that leg forward. And then at the same time you want to roll the vein out. It's okay, P. It's okay, P. For a saphenous blood draw, you want to have your patient in lateral recumbency, and then you want to hold on the leg where the blood sample is being collected just below the knee and hold the skin tight so that way you keep the vein from rolling, and that helps the person collecting the blood sample. To get an animal out of the cage, it's easiest to use a loop leash, especially for larger dogs. You simply loop it around their neck, and that allows them to come out easily while you still have restraint of them. For putting them away into cages, especially small animals, it's best to grasp under their belly and then hold under their chin when putting them into and taking them out of the cages. When muzzling a patient, you want to be sure that you pick a muzzle that fits snugly, but you don't want it too tight. That's a perfect size for Peanut. For an Elizabethan collar, when choosing an appropriately sized one, you want to make sure that it's long enough to where that way it prevents them from being able to reach any problem or incision area they have. You want to make sure that it fits snugly enough around the neck so that they can't just paw it off or simply get it off. Another key point is that you always want to run a collar through the loops on the Elizabethan collar. That way you can be sure that the collar, or the Elizabethan collar, fits snugly on them. Good girl, Peanut. This collar's actually a little bit loose, so I'm going to tighten it. Good girl. Okay, that looks perfect for her. When performing a complete physical exam, you want to be sure that you assess all of the body systems, assess a body condition score, a pain score, and of course TPRs for the patient. So for Peanut today, I'm going to start with her weight. It's okay. And she's about 10 pounds, 8 ounces. So we'll make a note of that. We're going to check her temperature, and I have an ear thermometer we're going to use for her today. She's got these nice big ears, which makes it easy. Good girl, good girl. Oh, that was low. Hang on. Let's try the other side here. Which one's ready? Ready. Alright, 100.5, so that's a good number. We'll check her respirations. I have a stopwatch over here helping me out. Okay, and that would be 24, so that's good. Next, I will listen to her heart. Oops, sorry dear. That would be 112, so that's a good number for her. I'm also going to listen a little closer. I thought I heard a slight heart murmur, so I'll double check that. Gonna check lung sounds as well. See if there's any abnormal sounds, any wheezing, crackling, anything that shouldn't be there. Sounds good. With the heart, there is a slight murmur. I would say maybe a grade 1 to a grade 2. So make a note of that. Then with the rest of the exam, I start with the head and work my way back. So I start with the eyes. They look a little bit foggy, like she might have slight cataracts, which I'm not surprised with her age. The ears, they look pretty good to me. I don't see any redness, inflammation, no discharge. Her nose looks good, nothing abnormal there. Checking in the mouth, check out the teeth. She's got a little bit of calculus tartar buildup. Sorry, dear. The gum color looks good, pink and healthy. 1 to 2 second capillary refill time. We'll check out her lymph nodes, just to be certain they're not enlarged. That's good. Check out the urogenital area. Looks good. She's a spayed female. We'll palpate the abdomen. You just want to be certain there's no masses, or see if she shows any signs of pain upon palpation. She's doing pretty good. Then next we'll check out the legs, paws. Right here. Looks good. Especially with older dogs, you want to check out the joints just to see if there's any pain, any early arthritis, or anything of that sort. There, dear. It's pretty good. So for Peanut, as far as a body condition score, I would give her a score of 3. She's an ideal body weight. Pain score, I would say a 0. She seems pretty happy, pretty healthy, doesn't show any signs of pain upon the exam. As far as her ASA grade, she would be a class 3, so she would be of moderate risk for anesthesia, just given that she has a heart murmur. I'll now complete a complete physical exam on our feline patient here. This is Chance. So I'll start with the TPRs for him. I'm going to check out his lung sounds as well. Okay, the lungs sound good, the heart sounds good, strong beat. It's pretty rapid, about 200, so he's a little bit nervous. Make a note of that. We'll check out his respiration rate. Wait for my timer to reset. Okay, so that's 32. Now I'll check his temperature using an ear thermometer. It's okay, Chancy. Good boy. Oh no, it's too low. We'll try again. Let's try here, there we go. Okay, so that's good. It's 100.1, so that's a good number for a cat. Next, I'm going to get his weight. Good boy. 11 pounds, 13.5 ounces. You're a big boy, Chance. Okay, so the same as with our canine patient, I'll start from the head and work my way back. Eyes, they look good. Just got a couple of sleepies there in your eyes. The ears, they do have a little bit of a waxy buildup. So I'll definitely mention that to the doctor to see if he would do an ear cytology on him. The nose looks good. I don't see any discharge, anything abnormal. The teeth, mouth, looks pretty good. He just has a little bit of gum inflammation on one of his premolars. The gum color looks pink, looks healthy. Capillary refill time, that's about 1 to 2 seconds, so that's good. Let's see, then we'll check out his lymph nodes, see if they're enlarged. Not feeling anything enlarged, that's good. It's okay. Okay, those feel good. Kind of check out the urogenital area. You're okay. He looks good. You're always going to palpate the abdomen. See if there's any signs of pain, any masses. He feels good. Check out all the paws. Chance likes to be dramatic, but he wouldn't hurt a fly. Okay, those look good, Chancey. So as far as a body condition score, I would give him a condition score of 3. He looks like a good healthy body weight. Pain score, I would give him a 0. He's healthy as a horse, happy, doesn't show any signs of pain. So overall, his ASA, he would be a class 1. So he would be a healthy candidate for surgery. Okay, now I'm going to collect a blood sample from the cephalic vein of our canine patient. I pre-clipped the area, and now I'm placing a tourniquet on the leg. I'll have you hold right behind your elbow. Just cleanse the area with the alcohol swab. Looks like 20, so I'll have you ready to hold off on that. Oh, perfect. And that's perfect. Okay, now I'm going to get a blood sample from the jugular vein of our canine patient. I've already pre-clipped the area, and now I'm just cleansing it with an alcohol rub. His hand up just a little bit. Good girl, P. Good girl. Beautiful. Okay, now Kelsey, I'll have you put your finger over the needle edge and we're going to pull out there a little higher. Perfect. I'll now collect a blood sample from the saphenous vein of a canine patient. Okay, that looks like plenty. Thank you. Okay, and we're good. I'm going to get a blood sample from the cephalic vein of our feline patient. Okay, so I pre-clipped the area. Now I'm going to cleanse it with the alcohol rub. I've also placed a tourniquet on the leg. And Kelsey, I'm going to have you roll out the vein. Just like put your thumb across it and then Okay, and that's plenty enough. So I'll have you put your thumb over that. Perfect. Take the tourniquet off. Perfect. And then we'll just put our blood and a blood collection tube. Now I'm going to get a blood sample from the jugular vein of our feline patient. I pre-clip the area, and now I'm going to cleanse it with the alcohol rub.
Get too shallow. There you go.
Okay, that's plenty, so I'll also put your finger. Okay, all done. Now I'm going to get a blood sample from the medial saphenous vein of a cat. I pre-clipped the area, so now I'm going to cleanse it with alcohol. And then I'm going to have somebody else hold off the vein for me.
That go in your hand there.
Okay. Yeah, over there.
Got it. Can you see it?
Yay. Yep, there we go.
Is it coming in your screen there?
Yep. That's plenty enough, so I'll go ahead and have you put your finger over that. Thank you. The minimum databases for young, healthy surgery candidates should include Paxil volume, total solids, blood glucose, blood urea nitrogen, and alanine aminotransferase. These are just starting points. Obviously, if you notice any abnormalities with the levels of any of these, you should pursue it further. But the reasoning for checking these few things, total protein, that's going to check the protein level in the patient, and that can be important depending on what type of anesthetic is used for them. Blood glucose, that's checking endocrine function, making sure they're not diabetic, anything of that sort. Let's see, Paxil volume, that's going to check like red blood cell concentration, check their hydration status. It'll tell you whether or not they're anemic or not. Let's see, ALT, that's checking liver function, and the blood urea nitrogen, that's essentially checking kidney function. For patients in our clinic, a pre-anesthetic blood panel is completed on our laser site and catalyst machine. So we run a full CBC, and then we complete a Chem 17 clip, a Light 4 clip, and an SDMA clip. This way we can be certain that we don't leave anything out of the picture. Often additional diagnostic tests are needed if you experience a patient with abnormalities upon exam. Examples of this would be if you have a patient and you hear a heart murmur or a heart arrhythmia, it would be good to do a follow-up ECG and have it analyzed by a cardiologist. Another one would be if you have an animal coming in who's experiencing vomiting and diarrhea. It would be a good idea to do a more extensive blood panel and check things like a CBC, check chemistries, electrolytes, and those will help to aid in the treatment of that patient. If, say, you have a patient who comes in, they're hit in the road by a car, brought in upon emergency, that would be one where you'd want to run radiographs just to check and make sure there's no broken bones. Let's see, if you have a geriatric patient, it would be a good idea to assess kidney and thyroid function. Often with older age, those can decline, the function of those both can decline. So the SDMA test, that's a really good test they have out now to detect early signs of kidney disease. Or a T4 profile, that might be a good one for an older cat since they're prone to developing hyperthyroidism. Today for a dental cleaning on a 12-year-old 10-pound Yorkshire Terrier with no known medical issues, the doctors ordered that we give a pre-med injection of Torb and ACE, or butorphic and ACE promazine. So for that, for the Torb injection, we'll give an injection of 0.01 milligrams per pound of body weight. So for that, I simply multiply 0.01 by the 10 pounds of the dog's body weight. So I know the injection will be 0.1 mLs of Torb. For the ACE promazine, that we kind of, it's dependent upon the animal. If it's a dog who's under 50 pounds, we really try to give a small dose of that. So we'll give 0.05 milligrams of ACE. Unless it's a really energetic dog, we might bump it up to 1 milligram. So if it's a dog who's 50 to 100 pounds, we'll bump it up to the 1 milligram dose of ACE. Emergency drugs, that's another really critical thing. You always want to calculate and have those ready ahead of time. I know in our surgery suite we have a big cheat sheet on the wall, but it just makes it a lot safer and a lot easier if you just pre-calculate those doses for your patient's set weight. So on our computer, we actually have an application here that allows us to easily do that. So for Bailey today, with him being 10 pounds, I simply go to the editing mode. I'll put in the 10 pounds of body weight, and this pre-calculates all of the doses of these different emergency drugs that may be needed for him. And then this will save in the patient record, and we actually print out a copy and we keep it with us throughout the entire procedure. When documenting controlled substance use in our clinic, we use individual logs for each controlled substance that we use in the clinic. So the example I'm going to show you today, I'm going to show you the butorphic controlled substance log. So for our patient that was anesthetized today for a dental procedure, I'm going to enter the information for the Torb injection. So on the log here, on this page here, this is showing we've started bottle number 2. We've had 1 dose drawn from it so far, so I'm just going to continue in the same format here. So I'll put today's date, and then I'll put the client and patient information, so that we print out these little labels that has all that information handy for you. Each time we use a controlled substance in the clinic, these will print, so it makes it real easy. Walker, not sure if you can see it quite good enough. Bailey, and then I type or write in the client's address. And then we also put the client's ID number. 36. Okay, so we're still on bottle number 2. I should say 2. The reason for notes, there's a section on here that says reasoning of why you gave it. So this would be a pre-anesthetic sedation injection. Amount used. Today for Bailey we used 0.1 mLs. And then you need to deduct that from your running balance. So it was 19.6, so now it's going to be 19.5 mLs. And then you have to put your initials next to it. We use H-size oxygen cylinders at our clinic. As you can see, they're securely chained to the wall. And then we note with these tags which one is in service, and if it's full, which this one is, or if it's empty, which this one is. We just keep track of that. And then how it works is the oxygen lines here, they actually run through the walls and the ceiling of the building, and then we have various wall connectors throughout the hospital that connect to the oxygen lines. At our clinic here, we use a rebreathing anesthetic machine. So how it works is, first, once we have the oxygen line connected to the oxygen wall connector, it then comes into the machine here. The oxygen comes to the flow meter first. So once you turn the flow meter on, you must read the bobbin, the top of the bobbin, wherever it lines up, that shows the amount that you have the oxygen set to. So the oxygen will come in at the bottom of that. And then from there, the oxygen travels to our precision vaporizer here. And we have an isoflurane precision vaporizer, as you can tell by the purple color. So once the oxygen comes in, you turn on your vaporizer. You always have to make sure that the isoflurane is to the full level. If it's not, you want to fill it up, and you would pour more of the isoflurane. Carefully pour the isoflurane into this reservoir there. But your isoflurane, it's only going to work if you have carrier gas present. So if your oxygen is not on, or if your oxygen tank is out, then the patient is not going to get any of the anesthetic. So from there, the oxygen and inhalant anesthetic then travels, it's making its way towards the patient through this outlet line here, and then it makes its way to the inspiratory unidirectional valve. So this will work whenever the patient inhales. It allows this to open up, and the anesthetic oxygen mix travels through the rebreathing tube to the patient. And how our tube works is the inspiratory breath brings the gas and oxygen mix through the inner tube, and that travels to the patient. And then once this is hooked up to an ET tube, the patient will inhale it. Once they exhale, the breath will go out through the outer portion of this tube, and that helps to warm up the inspiratory oxygen and anesthetic gas mix. But once exhaling, that then travels to the expiratory unidirectional valve. So that's only going to open when they expire, when they let out a breath. This is the pop-off valve here. So it's important that that's always open when the anesthetic machine is going. If it's not, if it's completely closed, that can really damage their lungs. It can cause the alveoli to rupture. This is a breathing bag. And first off, you want to make sure that you pick an appropriately sized one for your patient. But this allows you to observe the animal's breathing. It also serves as a reservoir. And also, in case you need to manually ventilate for the patient, this allows you to do that. From that point, the gas then travels to the CO2 canister. And this, it works by absorbing the carbon dioxide expelled in the animal's breath. So once the CO2 granules have been used up, it turns a purple color. I know the purple color, it does go away shortly after the anesthetic procedure is stopped. So we routinely change it every 30 days, if not sooner. From that point, the gases will then exit via, we have an active scavenging system. So it takes the expelled anesthetic oxygen mix out through this tube, and it then exits the building. It's basically uses vacuum suction to suck the air out of the building. Here we keep our designated puffer cuffer, as I like to call it. It's simply a 12cc syringe, and we use this to inflate the pressure cuff on endotracheal tubes. This is the pressure manometer. So this indicates the amount of pressure in the anesthetic circuit, and thus tells you the amount of pressure in the animal's airway and lungs. And when an animal is breathing spontaneously, the numbers here on the gauge should read between 0 and 2 centimeters of H2O. This lever here, this is the oxygen flush lever. So if you turn that on, it's going to rapidly deliver a large amount of oxygen to the reservoir bag here. So that's helpful to use at the end of a procedure when you want to flush out the lines, clear all the anesthetic out. Or if you have a patient and you need to perform CPR, that's really important because it'll deliver that large amount of air, pure 100% oxygen to the bag, and it'll allow you to ventilate for the patient. When inducting a patient, we use a mask. The mask fits snugly around the patient's face, and the opposite end connects to the rebreathing tube. It's really important that you choose an appropriately sized mask to help prevent waste anesthetic gas from coming out, escaping around the patient's muzzle. Sometimes we'll use a smaller one if we have a really tiny animal. Sometimes with a fractious or feral pet, you may need to use an induction chamber. How this works is you would place the patient into the chamber. It's a clear fish tank-like enclosure, but it does have a lid on it, and it'll have a portion where you'll connect the rebreathing tube in. That way you avoid harming yourself or the pet harming themselves during the induction process. If you're using a non-rebreathing system, there would be no CO2 canister, no pressure manometer, no unidirectional valves, and occasionally there's no pop-off valve. With the non-rebreathing system, they use high rates of oxygen flow, so that's why a lot of times they're recommended for patients who are under 7 kilograms of body weight. To perform a leak check of the anesthetic equipment, you must first turn on the oxygen tank in the back, or wherever it's located. I've done that previously. So then you'll want to turn on your vaporizer. You can turn it on anywhere from about 3 to 5 liters. The bottom set at 3. So then what you want to do, you want to make sure that you close the pop-off valve. And then make sure that you tightly cover the end of the rebreathing hose with your hand. You just want to be careful that you don't let any air escape once you turn on the oxygen flush. And you're going to fill the rebreathing bag up until the pressure on the manometer reaches 30. And it's reached 30, so now I wait for about 10 seconds. And I just want to make sure that the pressure isn't dropping. Really, you shouldn't drop any at all from the 30 mark. If it does, then that's when you want to start assessing possible leaks in the machine. Looks good. So I'll go ahead and I'll let off. Next, I'll place the pulse ox monitor on the tongue. You can place that on the tongue or on a pink paw pad. And that's going to detect the oxygen concentration of the hemoglobin. A normal number for that would be 95 to 100%. Now I'm going to place an esophageal stethoscope. You have to moisten it first. And this goes in the patient's mouth, down the esophagus. And this allows you to auscultate the patient's heart. For gastric intubation, you'll want to measure the tubing from the mouth of the patient to the back of the last rib. So it's similar to an esophageal stethoscope in that the tube will travel down the esophagus, but instead of stopping in the thoracic cavity in the esophagus, the tube will extend beyond that into the gastric area, into the stomach. And the first thing that you always want to do when you place the tubing is you want to moisten it with water or some lube, but it's key that you make sure you have it cut or measured to the appropriate size. And it's often necessary for a patient who's experiencing bloat. I'll start by placing the EKG leads. The electrocardiogram detects the electrical impulses from the cardiac conduction system. I remember it as green and white are always right. And Christmas comes at the end of the year, so red and green are at the rear. And then you have to moisten each of the leads with alcohol. And once they're moistened, you're good to start the EKG monitor. Our ECG is now going, so you can see that there's definitely the P waves, the QRS wave, and the T wave there. For the P wave, it may be a little bit prolonged. He could be experiencing first-degree AV block, but that's can be normal for patients undergoing the anesthetic. An endotracheal tube is used to conduct the anesthetic gas directly and efficiently from the breathing machine to the patient's trachea. They also work by helping to maintain an open airway. They reduce risk of aspiration. They reduce anatomic dead space, and they also allow for manual ventilation need be. When selecting an endotracheal tube for a patient, it's always best to have about 3 options prepared and ready. There's a few different ways you can tell what tube would fit your patient. Number 1, you can always reference an endotracheal tube chart, which will give you ideas based on the patient's body size, what tube might work best for them, or kind of based on their breed. Another way to tell is to take a tube and measure the tip of it between their nostrils there. And the tube should be about the same size as the distance between those nostrils. So far it's looking like Penny's a size 4. But you also want to measure and make sure that the tube is long enough that it goes from the tip of the nose to the thoracic inlet. Well, it's still Penny. So she's probably about a size 4. But like I said, it's best to have a couple different options ready as well. You also want to make sure that the tube, it's small enough to where it doesn't cause any damage to the trachea, but you want to make sure that it's also large enough that once the cuff is inflated, that it'll provide that barrier and prevent any aspiration of material. Another key thing you want to do is make sure that you use a puffer cuffer here to inflate the cuff indicator. So you inflate that, make sure that the cuff inflates properly, whoops, and that it retains its shape once you inflate it. But the best way to make sure there's no leaks would be to put this in a dish of water and just check and see if there's any air bubbles that come about it. That's about it. The respiratory monitor, that's located between the endotracheal tube and the rebreathing circuit, and it's set to alert a sound every time the patient doesn't take a breath for 10 seconds. To check the blood pressure, you want to apply a blood pressure cuff. You want to make sure it's a properly fitting one for your patient. You can place it on a limb or on the tail. And that'll assess their diastolic, systolic, and mean arterial pressure. But you have to inflate and deflate the cuff, so I'll manually do that now. The blood pressure for our patient currently, the systolic number is 102, diastolic pressure is 45, and mean arterial pressure is 53. The systolic pressure should be between 110 and 160. Diastolic should be between 50 and 70, and mean arterial pressure should be between 60 and 90. So I'll definitely notify the doctor of these numbers. The temperature probe, you want to insert this in the mouth, down the esophagus. A proper temperature for a dog or cat should be between 100 and 102.5. This is Dr. Hendrickson. He's my preceptor helping me throughout all my tasks. So, thank you.
You're welcome. Brianne's doing a wonderful job. She continues to learn. She's finding things, applying what she's learned in her textbook learning, and also learning how to apply it in real experience.
I'm now going to begin to prep the leg to place a cephalic IV catheter. So I'm going to begin by clipping the hair on the leg. You want to clip all of the hair that's going to come into contact with the IV catheter or any of the catheter components. Just be sure to get all the hair out of the way, out of the area. Okay, I'm now going to scrub the leg using the target pattern method. I'll use a 2% chlorhexidine scrub, soaked cotton ball, and then I'll follow it with 70% isopropyl alcohol. And you want to do this a minimum of 3 times. So now I'm going to place the tourniquet on the leg here. Place it just behind the elbow. Okay, and then next I'm going to open my IV catheter. So you want to be careful to use aseptic technique when opening it. Mostly the catheter itself, because that's what's going to be going into the vein. I'm going to open my plug here too, just to have it ready. Yes, you always want to get your light in a good area too to help you see better. So I'm placing the catheter. Make sure you place the beveled side up at a 10 to 20 degree angle. Once you see your flash of blood, you're good to fully insert the catheter. And then use a piece of tape to secure the catheter in place. Okay, now that the tourniquet's off and we're holding down on the catheter, we'll go ahead and take that out. Screw down the male adapter plug, and then you want to secure that into place as well with a piece of tape. And just to be sure we got the catheter in the vein itself, I'm going to flush it with saline here. Oops. I'm going to aspirate just to make sure I get blood. Yep. So we're good, and then I'll just put a piece of that wrap over top. Oops. There we go. And we're good. I'm now going to place a saphenous catheter into our canine patient. So I'll start by clipping the hair. Just going to get any hair out of the way. And now I'm going to cleanse the area with chlorhexidine scrub. I'll do 3 cycles, and then I'll follow each chlorhexidine scrub with an alcohol rub. Okay, so now I'm going to get my catheter all set to go. I have a 24 gauge IV catheter. Once again, be careful, make sure you use aseptic technique when handling the IV catheter. Make sure you see my flash of blood, which I do. Fully insert the catheter, and then go ahead and place your tape around the catheter. Make sure you do it snugly. Oops. Go ahead and I'll remove the needle here. Okay, I got my male adapter plug on. I'll put another piece of tape over the edge of that. And then I'm going to test the catheter just to be certain I'm in the vein. I have a saline flush here. Looks good. And then I'll just finish with my Vtht here. All done. I'm going to give a sub-Q injection of saline. All done. Now I'm going to perform an IM injection using saline. So to be sure, or once I'm in the muscle, I'm going to aspirate the syringe just to be sure I'm not in a vein. It looks good. So now I'll go ahead and inject the solution. All done. I'm going to give an IV injection of saline. So I place the tourniquet on the leg. I'm just going to cleanse the area with some alcohol. So I'll aspirate it first to make sure I'm in the vein, which I am. Sorry, then we'll remove the tourniquet, and then now I'm good to go ahead and give the rest of the injection. Thank you. And we're good. We're going to start the induction process. So we're going to start by giving some Vtht to our patient. And I'm just going to give half of the dose here and just see how he does with it first. It's okay.
You can do the next dose.
Okay. That's good. So now we're going to mask our patient. So we'll go ahead and we'll put the mask around his muzzle, and then I'm going to have someone help me hold it on him there. And then over here, we're going to turn our oxygen on to a rate of 2.5 liters. And then we'll turn our isoflurane on to 5%. And then I'm going to make sure I set a timer here. For about 3 minutes, and then we'll see how he's doing. We'll turn on our respiratory monitor. Oops. And then we'll assess how he's doing after about 3 minutes. Now it's been about 3 minutes, so I'm going to bump down the isoflurane 2%, and our oxygen down to 1 liter. Okay. So now we're ready to place the endotracheal tube for our patient. So Sarah, I'll have you take the mask off. I'm going to test the pressure cuff real quick here. That's good. Okay. Place a mouth gag into the mouth here around the teeth. I'll have someone support under the head. Okay, that's perfect. So we're going to reconnect the breathing tube here. And then we're going to inflate the pressure cuff. So I'm just going to close up the pop-off valve. And I'm going to inflate until I don't hear any air leaking from around the cuff. And then I'm going to connect the mouth gag to this clip here we have on the rebreathing hose. This is what's going to keep the endotracheal tube in place. But I also want to double check and make sure that I didn't insert the endotracheal tube too far. So I'm just going to listen here real quick and make sure I'm in the right spot. So I feel air coming out of the tube, so that means we're in the right spot. Thank you. Just gonna apply some artificial tears to both eyes here. That's good. Now I'm going to try to express the bladder if it's full enough. Just don't think it's full enough. There's a little drip. But for the spay, so I'm going to put from the xiphoid process down to the pubis. That looks good. Now I'm going to be doing a non-sterile prep of our canine spay patient. I'm going to be using 2% chlorhexidine scrub followed by 70% isopropyl alcohol rinse. The first thing I'm going to do though is take alcohol and I'm going to rub the hair down along the edges just to keep the hair moistened and down. Here, sorry. That's good. So now I'm going to start the chlorhexidine scrub. I start right at the incision area where the doctor's going to be making the incision. And I use the Target scrub pattern. And you want to do this a minimum of 3 times. I'm gonna do one more. Belly's pretty dirty here. Okay, that's good. Now I'm ready to perform the sterile scrub since we're in the surgery suite. So I have sterile gloves on, and the 2 canisters here, they're sterile. The sponges in them are sterile as well. And it's chlorhexidine scrub, 2%, followed by an isopropyl alcohol rinse once again. So I'm just going to fold in the corners, and once again I start at the incision area using that same target scrub pattern. And you want to do this a minimum of 3 cycles as well. And we're good. Now we're ready to transfer her to the surgery room. Today for our patient we're using isoflurane. We started at 5%, and then at about 3 to 4 minutes we dropped it down to 2%. And our oxygen, that's the gas we're using today, we started at 2.5 liters, and then at the 3 to 4 minute mark we dropped it down to 1 liter. Other things you want to chart, every 5 minutes you want to do heart rate, respiratory rate, pulse ox, end-tidal CO2 if you're using that, and then your blood pressure, noting the systolic, diastolic, and mean arterial pressure. Temperature, you chart that about every 15 minutes. And then if IV fluids were given, you would chart those every 15 minutes as well. You would chart the rate that you're going at, and then the running total as far as like how much fluids they've gotten so far. Other things that you want to chart, of course, your anesthesia start time, anesthesia stop time, and then your procedure start and stop time. On here I kind of make my rough notes, and then in the computer system we actually have a more detailed form. We'll input these numbers, and then I'll also scan in this form once it's completed. So it's been about 5 minutes and we're ready to check on our patient. Okay, so in here, temperature, it's about 97.5. I'll just make a mental note of that. It's not really noted on the chart. Pulse ox, he's at 99%. Chart that. Heart rate's at about 92. Respiration's 32. Blood pressure, I'm just going to manually inflate that, and I'll check that once it's done. This is our canine neuter patient today. Bit past the 5-minute mark just with having to inflate the cuff, so I won't note it exactly on the line. But the systolic is 176. Diastolic 85. And mean arterial pressure 138. Pretty close to the next temperature check, so I'll make a note of that. So it's 97.5. So that looks good. If you have a patient experiencing CPA, you're going to want to begin CPR stat. So the first thing you want to do is get your patient in lateral recumbency, and you're going to want to begin chest compressions. And you want to do this at a rate of 100 to 120 compressions per minute. So it's easiest to think to yourself, just sing the Bee Gees song in your head, the Staying Alive song that everybody knows. And when you're doing these compressions, you want to compress, or make your compressions at about 1/3 to 1/2 of the width of the chest. And you want to make sure that there's full elastic recoil between each compression. So at this time, while you're doing the compressions, it's ideal that you have a second person to help with the respiratory, or excuse me, to help deliver the oxygen to the patient. So with that, if your patient isn't intubated, you'll want to do that, have that second person intubate them. And then once they're intubated, then you'll connect them to the rebreathing circuit here, and they'll deliver 100% pure oxygen to the patient. So I'll show you that here. So once this rebreathing hose would be connected to that endotracheal tube, that second person here would use the oxygen flush button or trigger, and they would fill up that rebreathing bag, or reservoir bag, excuse me. And then with that, while that person's giving the chest compressions, this second person would be in charge of administering the breaths for the patient. So you would want to do about 10 breaths per minute. And it's important that the person looks at the patient's chest, because you want to mimic as normal as a breath as you can. Obviously, you don't want their chest expanding to an unsafe level, and you also don't want to take too long making a breath. So it's really super critical to just get going as soon as you can when you notice cardiopulmonary arrest, and it's really helpful if you can have multiple people. Okay, now I'm going to scrub in. So I already have my booties on. I'm going to put on a mask and then also a bonnet. I'm going to open my gown and my gloves before I scrub my hands. Oops. That looks good. Okay, now open the gloves. Good. Okay, so now I'll come down here. We use the Avogard alcohol-based hand rub. Before you do that, you always want to clean under your fingernails with a nail pick and then wash your hands first. I've already done that. So now I'll go ahead with the antiseptic. So I do one pump into the palm of my left hand, which is 2 mLs, and then I rub my fingernails in the solution, and then I want to make sure I get my whole hand, and then rub the solution back to my elbow. I'll repeat the same process, but into the opposite hand. Once again, rubbing down to the elbow. And then you do a third and final pump and just mix it between both hands, making sure that you get each finger coated well. The front and back of the hand. And then you only go to the wrist. And then you want to let things air dry for a bit before you open the gown. Sometimes it takes a little bit longer to air dry. Okay, that feels pretty good. So now I'm good to open the gown here. Okay, so once I locate the collar of the gown, then I look for the armholes, and then I'll insert my arms into the holes, but I don't want to put my hands all the way through the gown. So then I'll have someone tie me in. Thank you, Kelsey. It's okay, it's not technically sterile behind me. Oh, thank you. Okay, so now for the gloves. You want to do the palm to palm, thumb to thumb with the fingers of the glove facing towards your elbow. Just kind of wiggle your fingers until they're in the right position. Okay, now I'll get my left hand, whoops. And you want to make sure that the cuff of the gown is completely covered by the gloves. Okay, I've already had a circulating nurse open the surgery pack here, so I'm going to organize everything in the pack. We have our sutures and our blade here. First I'm going to count the sponges. And I see that we have our sterilizer strip and it's acceptable, so that's good. 20 sponges, that's good. Okay, so that's good. So there's 18 tools, 20 sponges. So now we're going to drape the patient here. And we use a paper drape. So the doctor will make the fenestration in this drape, and then after he's made that fenestration, then I'll go ahead and I'll place the towel clamps. Actually, I'm going to come to this side. Okay. So now I'm going to moisten the abdominal cavity here. So I'm soaking it in a sterile saline solution. That's good. So now I'm just going to block some blood. Okay, now I'm going to load the scalpel blade onto the scalpel handle. Oops. That's good. Once the doctor's ready, I'll hand it to him. Doctor needs thumb forceps. Duty and responsibility of a sterile technician are to maintain sterility and to assist the surgeon. You may need to do things such as manage an instrument table, hand the doctor whatever instrument he may need. You may have to moisten the body cavity, use a retractor to help the doctor see better. You'll have to count the instruments and the sponges just prior to the doctor making his opening, and then also just prior to the doctor making his closing with sutures. You also may have to prepare sutures for the doctor, have them loaded and ready to go. Another thing, you might have to maintain hemostasis throughout the procedure if the doctor asks you to. So once you are sterile, it's really important that you don't turn your back to a sterile field, and you'll always want to keep your hands above your waist in that sterile zone. So obviously don't touch any non-sterile item. So it's really helpful to have a circulating nurse who's not technically sterile. That way, if you need any additional like peel away pouches, such as like a glove, if you need additional sutures opened, they're able to do that for you, or sterile packs, of course, because though the item inside them might be sterile, the outer pack they come in is not. If you break sterility, you must use your surgical conscience and correct it. For example, if I were sterile, I had sterile gloves on and I accidentally punctured my glove, I would have a circulating nurse come in, open the outer pack of a sterile pack of gloves and allow me to put on a new sterile pair, and then I would dispose of the punctured one. Or if I were to drop a tool on the ground, I would have a circulating nurse come and bring me a new surgical pack if there was another backup pack available, If not, another thing you could do, you could take that tool and flash sterilize it in an autoclave. So basically what you do there, you would place the tool on a tray, and you get to bypass the whole packing it in an outer pack, and then it takes about a 20-minute cycle in the autoclave before it's ready for the doctor to use it again, which is fairly quick. Now that we've cooked the hair for our canine patient, I'm good to run the non-sterile prep of the area. So I'm going to use the 2% chlorhexidine scrub followed by 70% isopropyl alcohol rinse. And I'm going to use the Target scrub pattern. I'm going to do one more because he's a little bit dirty here. Okay, and we're good. We have our feline castration patient here today. We've performed a non-sterile prep as well as plucking the hair from the scrotal area, inner treatment area. We've now moved him to the surgery room, performed a sterile prep, and now we're going to go ahead and get things started. And I'll start by opening the surgery pack. And I'll go ahead and open the surgery blade to the doctor. I'm now going to hold the leg of the feline patient here just to help the doctor perform the procedure better, but I want to make sure that I stay away from the sterile field. I've completed the non-sterile prep for our feline spay, and we brought her into the surgical suite. So now we'll begin our surgical prep before completing the spay. Now it's time for the post-surgical cleanup of the surgery suite. So I start with the tools and the sponges, medical waste as well. On here, if there are any blades or suture needles, I would dispose of them into the sharps container. The doctor's actually already taking care of them for me. Normally he's pretty quick about doing that first. But if I needed to take the blade off the scalpel handle, I would use the needle holders only. It's the only tool designed to hold metal. I would take that off, and then I would carefully walk and dispose of it into our sharps container we have just outside of the surgery room. Same thing with the suture needles. Be very careful handling them, and then dispose of it in our sharps container. The sutures we use here primarily are all disposable. So I'll bring this a little closer here. So on here, from our canine castration, we have the testes. So we're going to dispose of them into our medical waste bag. Oops. So the first thing we do here, we weigh them. So about 2 ounces for the two of them, and then we just make a note of that in our infectious waste log. This technically isn't infectious waste, it's biomedical waste, so it kind of, our log doubles as both. So I put today's date, which is the 23rd. This is pathological waste or on tissue, organs, body parts, and fluids. So I'll put category 3. Canine testes, 2 ounces. And then I'm going to dispose of it into our red hazardous waste bag. Now I'm going to dispose of the testes in our red biohazardous waste bag. I'm going to go ahead and pre-soak our tools and decontaminate them. So you also want to double check your sponge and tool count. This is kind of like a double check because you check them just prior to the doctor making the closing sutures on the patient. So our sponges, we started with 20, so we have 1, 2, 3, 4, 8, 6. Okay, so I have 18 here, which makes sense because I just threw 2 away in our medical waste bag, so we're good here. I'm obviously going to dispose of all of the used sponges here. Our tools, we started with 18 tools, so I'll count them as I'm placing them into our dish here. I'll show you this because what we have here is Spectra soap. So this is like our pre-mixed up jug. So what it is, it's a mixture of distilled water with this Spectra soap high suds detergent. It's specifically used for surgical instruments. Okay, so that's perfect. All of our tools are present and accounted for. Back to the pack here. For our drapes, we also use a disposable drape, so I'll go ahead and I'll dispose of this. And then we have some empty tissue mend glue, so I'll go ahead and I'll dispose of that as well. These here, these were from our suture materials. They're disposable. Well, it's trash, we'll take care of that. And then obviously this blue drape here that was used inside the pack, I'm going to wash this. I can see there's a little bit of blood on that, so I'll be sure to take care of that as well. So now I'm good to turn off our water blanket here, our warming blanket. I'm also going to turn off the lamps here. I'll take care of any other materials in here that I can dispose of or put away. Our esophageal stethoscope, I'll put this away. And then also the tube portion in our chlorhexidine solution. I'll put our blucher away. Some gloves I'll dispose of. Our absorbent pad I'll dispose of. Off our ECG leads, pulse ox monitor, our temperature probe, and just the anesthetic cart in general, using some disinfectant wipes. We use the Rescue ready-to-use wipes. just going to do white for the cart here in general. Okay, that looks good. I'm going to use the Vtht disinfectant. It's also a viricide. So I will start with surgery lamp holders here. These I'm just going to clean because sometimes blood and other bodily fluids can get contaminated on here when you need to move the lights around. I'm going to do the same on the handles here of the lamps too. You just kind of want to inspect them in general, make sure everything looks clean. Then next to do our water blanket here. Spritz it with the Vtht. We're actually going to let this soak and air dry. But obviously if there's any like blood or any other contaminants on your hair, you'll want to take care of that. That's good. And then I'll come over to our carts and that we used, and I'll clean them off as well with the disinfectant. Finally, to complete our terminal cleaning in the surgery suite, I'm going to use a wet vacuum here. It's specifically labeled for surgery room use only, and it's preloaded with the Vtht disinfectant and viricide. So I'll start in the corner there and I'll work my way back. I just want to make sure I get all areas of the floor here, and I really don't want to retrace the steps that I've already walked in and that I've already cleaned. So this way I'm just moving any debris that were on the floor in the surgery room here. I'm just moving them out the door with me. Let's back this up a tidbit here. Oops. Okay, and we're all done. To finish properly cleaning the surgical instruments, I'm going to scrub them with the soft bristle brush. And I always wear gloves. And for each tool, you want to make sure that you get in any, like, all the cracks and crevices and the joints and box locks. So that was our last tool. So then what I do, I just kind of rinse them off with some distilled water just before I put them in the ultrasonic. To prepare a surgical pack, I always follow the template our hospital uses for preparing a surgery pack. With this, the first thing you want to do is cut out a piece of disposable drape. We use like a paper disposable material, and then you always want to line it with a lint-free towel, and then you just go in the order as far as how to place the instruments. So I'll just go through that. Straight up there. 4 towel clamps. 1 scissor, 1 needle holder, 3 curved hemostats, 1 curved angiotribe, 4 straight hemostats, and then the next thing I'll do, I'm going to spray all the box locks and joints with some lubricant, instrument lubricant. Okay. And then next in our pack, we're going to put a surgical drape and sponges. I pre-counted out my sponges. I'll just double check them again. We'll always put 20 in our pack. 2, 4, 6, 10, 6, 8, 10. And then we have our disposable surgical drape, and we fold it accordion style, of course. So place the sponges just right on top of the tool, just as it shows in our template. I'm going to put my steam indicator strip right in the middle there. And now I'm good to go ahead and fold the towel. And you fold it in a manner that makes it easy to open up once you're opening up the sterile pad. So that's good. And now I'll proceed to fold in the drape and use the angled folding method here. Basically, this way you're making little pull tabs that make it easy to open up. Leave that there for a minute. And you finish off by folding this last edge. Oops. You fold the last edge into this little pocket here. And then you leave a little pull tab there, and that's how you'll start to open the pack. And then last but not least, you want to seal the outer pack with some steam indicator tape. Just on the tape itself, you write what exactly you're packing, which this is our surgery pack. You put the date, today's the 23rd, and then your initials. That way if anything's wrong with the pack, we'll know who was responsible for packing it. And you place that right in the middle there. Okay, and that's all set. Once your surgery gown is clean and washed, you're good to begin preparing it to pack it. So the first thing you want to do is you want to lay it on a flat surface with the outer portion of the gown facing up. And then just make sure that the back of the gown, the edges meet in the middle here. You want to straighten out the arms, like the sleeves, the cuffs. Okay, and then next you want to fold the gown in half again so that one side meets in the middle. You do the same with the opposite side. And then you want to fold it in half again lengthwise. Oops. And now you're good to fold it up accordion style. And then you always want to make sure that the neckties are right up top, so it makes it easy for whomever's opening the sterile pack. They can just grab the neckties and the gown will come out easily from the pack. I've already prepared the paper outer pack wrap. I placed a lint-free towel in the center and I placed my surgical drape in the middle. So I'll put a steam indicator strip right on top of the gown and I'll proceed to fold the towel in the appropriate manner. And now I'm good to use the angled wrapping method to finish wrapping the gown here. Get it nice and tight here. There we go. So I left my little dog ear there, and then I'm going to finish by sealing the pack with a piece of steam indicator strip, or steam indicator tape. I'm going to write a description of what's in the pack, which is a surgery gown. I'll put today's date and my initials, and I'll put it right on the center of the pack. All done. This is a gravity air displacement autoclave. It uses steam under pressure to kill microorganisms. Basically how it works is distilled water fills up at the bottom of the chamber here. And then that water gets heated up until it turns into steam. And then steam pressure builds up in the machine. Some of the steam will escape out through a port in the machine. But once enough pressure has built up, it'll heat things to the appropriate temperature. And then after that cycle has been completed, the steam, it'll condense back to water. So if the autoclave does its job properly, everything inside of those packs have become sterilized, meaning that all microorganisms have been killed. There's 3 key things you want to make sure you follow when handling an autoclave. First, you want to make sure that you properly follow all the operation, or properly operate the machine. You also want to make sure that you follow proper pack preparation, and you also want to properly load the machine. So I've already shown how to pack items properly, and it's always a good idea to pack them in a pack and proper, like a designated pack prepping area. Proper loading of the machine, that means that you don't want to overload the machine. So when you fill items in that chamber, they should never be packed so full that they touch the inner chamber. And then proper operation, you just want to make sure that you follow all the steps properly and that the machine reaches the appropriate temperature and pressure. So at our hospital, we have a little cheat sheet here that we always follow that tells us how long each cycle should last and which way you want to turn the knobs. So first you have to load the machine with the packs, and then you have to fill the machine with the water, the distilled water at the bottom. And then you'll have to set the machine to sterilize. Next comes the steam step. After that is venting, and then after that you'll want to slightly crack the door open just to allow the machine to vent some more. Okay, now I'm ready to load the chamber. So I'm just going to load them here on the bottom tray. And I'll make sure that I'm careful that I don't overpack the autoclave. So I don't want anything really touching the sides, the inner sides of the chamber. That looks good. So then next, I'll just follow my template here. So I'm going to fill the machine here with the distilled water. So I just turn it to fill. And then the distilled water comes from the reservoir tank, and it's going to fill up the bottom portion of the autoclave here. That usually takes about a minute or so. Another thing you have to make sure is make sure it's filled with distilled water. Over here is where you would fill the water. I've already done that prior. There's a fill line in there that tells you where you want it always full to. And then in here there's a little plate, and you want the water, as soon as the water touches that plate, that's when we close the door and tightly shut it. Okay, that's good. I'll shut that. So now I'm good to set the machine to sterilize, and we'll come back to things. The proper temperature the autoclave should reach should be between 250 and 270 degrees Fahrenheit, with PSI measuring between 15 to 27. On average, it takes about 15 minutes for an autoclave to reach these proper numbers. Our machine, however, takes about 30 minutes. And we're good to go to the next cycle now. So follow my sheet. Okay, we'll come back to things. So then once done, the door should be allowed to properly vent for about 10 to 15 minutes. It's important to run routine maintenance on your autoclave. So once a month, we actually run a bacterial spore test strip in our machine here, and then we send it out to Mesa Labs, where they then verify whether or not the test strip was properly sterilized or not. Another thing you want to do is you want to routinely clean your autoclave. So once a month, we actually have a monthly maintenance cleaning protocol. So we'll run a cycle through the autoclave using the Speed Clean autoclave cleaner. And then after that cycle is done, then you follow up by spraying inside the chamber with the SpectraClave. It's an autoclave cleaner and descaler. Then you have to let that sit for a little bit, and then you take a wet towel and clean the inside out. So yeah, it's really important. You know, if you take care of things, they will last. To ensure pack sterility, you can look at the steam indicator tape on the outside of the packs. And if you see the black lines on it, then that means that steam properly penetrated the tape, the packs itself. But the surefire way to tell that the pack met proper sterility requirements would be to open the pack and check the steam indicator strip. So when you look at that strip, if the black mark reaches the acceptable portion, then that means that you met proper pack sterility requirements. We performed a tissue punch biopsy on Chance. He had a small growth on the top of his head. So we placed one staple in. So it's ready to come out. So I'm going to go ahead and remove that now. Okay, easy as that. I could tell the staple was ready to come out of our patient following the punch biopsy because there's no redness, no swelling, no drainage, and there's no gap between the closure area. And those are really 4 key things that you want to look for that tell you a suture or staple is ready to come out.